They're in a consortium, they're not freestanding. So your consortium either chose to be grandfathered or not, and added on some of the services that healthcare reform added from 2010 on. If I'm self-funded, again, self-funded got no exemption for me. Collectively bargained health plans are fully subject to the law at the same time and in the same manner as self-funded group health plans. Based on a plan, they can be grandfathered but have no special status. So a lot of people thought that if just because I was self-funded, I could avoid healthcare reform. That's not the case. Recap of healthcare reform. 2010, 2011, 2012, we call these the feel-goods. Bottom line is these were all things that everybody didn't argue about. We in New York State, we only suffered about a 6% increase on our fully insured business since 2010. We were a heavily mandated state. So we had a lot of these services that were already built into our plan. 2010, extended coverage for young adults, federal high-risk pools, federal retirement reinsurance program. We'll go over some of these as we go. One of the things that was hidden in the law is there was an indoor tanning tax. And then the grandfathered option that I just touched on. If anybody has any deeper questions about grandfathered plans, grandfathered status, you would have had to issue each and every year since 2010 a statement to your employees stating that your plan is grandfathered. So I don't know if anybody's done that or not. Medical loss ratios. New York was ahead of this curve. New York basically had medical loss ratios set up. And what that meant was that if I had for small group, 85% of my premium had to be spent on claims. If I'm large group, 80% had to be spent on claims. So we already had that in New York State. The federal government did that as well. And what they did that for was they wanted to make sure that insurance companies were keeping their overhead down. And then they were also doing a checks and balances with Human Health Services is now going to engage as we move forward and check that the insurance companies are spending the premium that they say they're spending when they're asking for a rate increase. So it's a good checks and balance. It probably will slow down the process from a rate renewal perspective going forward as they're justifying that. Preventative health. Again, New York had the majority of these services already in place. Small group this year, you're seeing the implementation of essential benefits. And then, trying to see what else. 2012, everybody heard it. I like to relate this story because my mother's 77. And in 2012, August of 2012, she said to me, she goes, Mike, isn't it so great that your kids aren't going to have to pay, your daughters aren't going to have to pay for birth control? Because the only thing that came out of that was basically that I got free birth control. That's what everybody heard, and it was all over the news that we were getting free birth control. I said to my mother, I go, Mom, love you, but it's not free. There's a cost in it. You're just waiving the copay. All our president did was mandate that the copays be waived for generic prescription medication on birth control. The claim still happens. So as a consumer, we got something that was positive, was good, but there's still a cost to it. 2013, we had FSA contributions capped at $2,500. It's important to note the FSA. I don't know if a lot of districts are incorporating FSAs or offer them, but this will be used, and you'll see it towards the end of the presentation, to calculate towards the Cadillac tax. All pre-tax dollars are going to be used to calculate towards the Cadillac tax. Exchange notification requirements. This was where everybody was challenged this October. They had that one-page form that you had to complete. Does my plan meet minimum value? Is it affordable? Every consortium, NISHIP plans meet minimum value. Your union contracts pretty much mandate that they're affordable. But to do the calculation, you still need to do it. I was doing a presentation down in Philadelphia on September 10th. And September 11th, the DOL issued a notice. And I had told everybody, you have to get this out by October 1st. Otherwise, there is a $100 per day per employee penalty to the Department of Labor if you don't get this out. And September 11th, Department of Labor issued a letter that said there was no penalty. So I had to call everybody in Philadelphia and tell them, okay, what I told you yesterday now has changed. That's how quickly this law is changing. But next year, you're going to be required to fill this out. And it, again, minimum value, Human Health Services has a tool that you can do that. We'll talk about it as we go further on. Summary benefits coverage. Last year, the insurance companies got a buy. This is an 8-page document. Most of your TPAs are doing this for you. Some charge, some don't. Your insurance carriers on the fully insured world, they're doing this for you. They're giving it to you. It is your responsibility as an employer to get this to your employees. 60-day notice of material plan changes. This is going to be a change from a union perspective. Typically, when you're negotiating contracts, you negotiate a contract, it may take you a year to negotiate a contract. It may take you longer. Basically, after your negotiations are done, you have to give a 60-day notice to everybody in that bargaining unit prior to making the plan change. So you have to work with your carrier or your TPA, and that will also force another summary of benefits coverage, an SBC, to be issued to all those employees on the bargaining unit. So that is a change, and it's going to become a challenge as you're going through these contract negotiations. Again, working with a consultant, working with your TPA, your carrier, they'll make sure that you're compliant with this. W-2s. 2012, we had to, any employee that had 250 employees or more had to issue and include how much are you paying, how much is the employee paying for their health care, and how much is the district paying for their health care. Little known fact of why that's being used, this is what our government is using to calculate the Cadillac. So they're putting a 7% trend factor on those dollars. They know what we're paying now as employees, and they got our employer contribution. And they're knowing how many of those groups are going to be over the $10,200 on individual coverage and $27,500 per family. So that's a tool that the CBO actually implemented so that they could budget. The other thing they're using that for, if I don't have a box filled on that, then they know I don't have insurance. If there isn't a pre-tax deduction on there, then that's a red flag for them to ask, do I have coverage? 2013, fees and taxes. They're going to be eliminating the deduction for the Medicare Part D subsidy. Increased threshold for medical expense deductions. This is an individual tax. Basically, right now, I could up to 7.5% of my income, or 7% of my income. They've raised it to 10%, where I could itemize my uncovered medical expenses and take that deduction. So it's a 3% increase of me being able to deduct when I have those bad years. Additional hospital insurance tax for high-wage workers. Our government has defined high-wage workers as an individual who earns $200,000 or a family who earns $250,000. That is deemed as high wage. The hospital insurance tax for these high-wage workers is 3.9%. Medicare payroll tax increases. Now, this is a struggle. There hasn't been any clarification yet. You as an employer don't know. You set up the deductions through payroll. You don't know if that individual is a high wage. You know what the individual makes, your employee makes. You don't know what their family makes. I've heard some accounting presentations that say it's an employer's responsibility to set that number correctly. I don't see how that can happen. What I see happening is that individual, if they make $200,000 or they make $250,000 as a family, I see them settling up at the end of the year with the federal government on their individual taxes, that additional 0.9% increase that they're going to get for Medicare taxes. And then probably one of the most talked about medical device excise tax. Pennsylvania, you heard a lot of noise from the state. They have a lot of medical device manufacturers in that state. It's a 2.3% excise tax. We asked our federal legislators when we were down there. We said to them, who's going to pay this? Medical device manufacturers. You don't get it. Bottom line is, what's happened is this is a flow-down system. Our healthcare system absolutely flows down to us, the end consumer. The medical device manufacturers put the bill on to our providers. The providers put the bill on to us as far as a claim. We pay that additional claim. So you, as a consortium, you're going to increase your claims for any medical device 2.3%. This goes even further because what the medical device excise tax affects basically anything that can be used by a human. The ADA, our dentists use some of these medical devices. Our ADA has actually issued a letter to all of their dentists and said, increase the fee schedule 3%. They didn't want to look at what services they had to apply this tax to, what they didn't have to apply this tax to. So they increased their claims, basically, or our claims, 3%. They got a 3% pay raise, or actually a 0.7, because they had to pay the 2.3 as far as a tax to the federal government. Goes one step further. Impacts us if we show up at the vet. Because those devices that are used on our animals, that a human could use, also incurs that tax. So we get hit one more time as we're treating our animals. Patient-centered outcomes, Research Institute. This is a fee that came in 2000. If my plan renewed after October of 2012, it was $1 per covered life. Fully insured plans, the carriers are building it into the rates. And they have to collect this on your behalf and pay it to the federal government. Self-funded plans, basically your TPA has been doing this. But plans after 2013, it raises to $2 per covered life. Any district, and I want to point out to the bottom here, any district that is offering an HRA, health reimbursement account, the federal government has defined that as a health plan, even though it may be a set dollar amount that you fund into that account for that employee, you also have to pay this patient-centered outcome fee of $1. $2 per life. So you have to pay this on a Form 720. It's payable in July. It is your responsibility as an employer to do this. Behind it, it's a good part of the law, but it does cost. And it's a comparative effective research fee. And basically what this is this is supposed to transfer best practices from one point of the country to the other. An example I've used in the past is, it's a well-known fact in the East Coast that a beta blocker given to you after you have a heart attack prevents that second heart attack. It's not the case all across the country. So transferring that information as a nation, we could actually get better outcomes. But again, it's being financed by us through our premiums in order to pay for this. 2014, this is another thing that I'll say that we didn't have, or we had in New York State for the most part. We didn't have pre-existing conditions. We did in small business, and that was only if I had a gap of more than 63 days of coverage. But we didn't really have it. Not many people got caught in the cracks. But as of 1/1/14, there are no pre-existing conditions. Insurance premium restrictions. This gets back to the point that I had talked about, that basically now we're going to have the insurance departments of the state, or we're going to have Human Health Services looking over the shoulder of the carriers as they're asking for rate increases to prove that they're spending the dollars from last year's experience. Annual limits, again, New York, for the most part, most of our plans, we're not sitting with $1 million plans anymore. We're sitting with unlimited benefits. We had a few benefits that did have caps. Excessive waiting periods, it can't be any more than 90 days. So if an employee hires, you hire them, and they're eligible, they're working 30 hours or more, you have to offer them benefits within 90 days. And it's not the 91st day, it's very specific. It has to be on the 90th day of employment. Small group, essential benefits. I know everybody in this room is pretty much a large group. But essential benefits, we had them in New York State. Again, this was not something that was earth-shattering. There was no benefit that was defined by the federal government as an essential benefit that we didn't already have. Out-of-pocket maximum applies to all non-grandfathered plans. This is probably the single biggest thing that you're hearing on the news. When our president said, number one, he said grandfathered plans was how we were all going to keep our benefits. And then we were up to millions of people losing their policies. Well, they're losing their policies because they have to comply to the law. They have defined what the out-of-pockets have to be. No worse than $6,350 for an individual and $12,700 for a family. Most of the plans didn't have these accumulators. Matthew and I were talking before we started, and one of the questions came up of if the Republicans take power in the next election, is this going to be rolled away? Well, the insurance companies have had to build these claim systems now to accommodate the law. What's unique about these limits is in our past we had copay structures where we went to an office visit, we had a copay. Prescriptions, we had a copay. A lot of plans had deductibles or coinsurance for inpatient hospital, outpatient surgery, things of that nature. The out-of-pocket only applied to the inpatient and outpatient services. Going forward in 2014, that out-of-pocket has to incorporate all my copays, all my prescription copays, which becomes a bigger challenge for self-funded plans who have, and they've actually got a pass for 1 year. In 2015, they have to comply with this. If I'm a self-funded plan and I have two different administrators, I have a third-party administrator processing my claims, and then I have a separate pharmacy benefit manager, those systems have to talk to each other. So they've given them until 2015 to be able to talk together. And then to be able to accumulate all the copays that I'm hitting on my prescription benefits into that out-of-pocket max. So it has been a drastic change of how healthcare has been delivered. These operated very similar to our high-deductible health plans or the HSA plans, where every service that I had was subject to that deductible and coinsurance. But in the school district and consortium world, those plans, for the most part, don't exist. So it is a drastic change of how we receive our health care. those apply, the limits of employee cost share for essential health benefits, that really applies more to the small group marketplace. And we'll go to the next slide. There's two major components that I'm going to spend the bulk of the time of our conversation on today, and that is on the variable employees, the minimum value, the affordable coverage that you're going to be subject to, and then on the Cadillac tax. But I want to give you an overview of everything that is pertinent that you are eligible for from a large group perspective to do. One of the components that exists is a wellness incentive. Whereas I have some groups, even in a union environment, that basically will incent employees to get biometrics done, to take a HRA, a health risk assessment, and then that data will be compiled, and then the groups will offer a wellness program. Those two pieces of compliance, doing the biometrics, getting a group aggregate report to the employer, as well as a health risk assessment, allows them to get an incentive off their premium. The law stated that you could get 30% of the premium as of 2014 for any employee participating in the program. One of the things is we were sitting in Washington, and I asked the question, okay, this wellness incentive, I get it, but you're making my employer be responsible for 9.5%. I can't charge them any more than 9.5% for their coverage to make it affordable for them out of their W-2 Box 1. I said, now how does this apply? Is this before or after? Actually, what this says, an employer who offers a program like this now has to assume 100% of the people fail to get the credit. So I can charge no more than 9.5%, but I could give a 30% subsidy on that 9.5%. So you're only going to be judged, even if you went into and offered a wellness program, you're only going to be judged based on their W-2 Box 1, charging them no more than 9.5% of it, and comparing it to the single plan offering that you have. So you can't, those smokers that you've pushed it all the way out to the end of the parking lot and they still do it. You pushed it off the property and they still do it. You can't penalize them anymore for the premium. But the law says that you could do up to 50%, or an additional 20%. But hidden behind this bullet is you have to provide them unlimited amount of smoking cessation, allowing them to try and quit year after year. So it was another good intent of the law, but was wiped away with the affordability component on allowing employers to be able to massage that. Anybody else watch that show other than me? Great show. Delayed until January 2015, and this is where the employer mandate, this is where we're going to spend a lot of time. This is where actually, I want to say it was about 4 months ago now that they actually delayed this. And the Congressional Budget Office, the day after they delayed it, came out and said it's a $10 billion giveaway. Meaning the penalties that we were going to impose on our employers is $10 billion. When you look at how we're funding for healthcare reform is being funded by penalties, by taxes. So we gave this up because they felt that large group employers could not comply with this year. Well, within 48 hours, the CBO came back and said, whoop, my number's wrong. It's now $13 billion. And you know that they had, or excuse me, it was $12 billion. So they had made a $2 billion calculation error. You know that in 2015, they weren't going to be able to catch everybody that didn't comply with the law. So they had budgeted round 2 of catching those employers that were non-compliant. So maybe it was $6 billion. If they were off at $12 billion for this year, then maybe they assume that half of the groups were still non-compliant. They were going to get half of the number of revenue. They're $18 billion behind the 8 ball right now by allowing this 1 year to pass. So as we get deeper into this, published in the law is you saw an employer can be penalized either $2,000 or $3,000. You've heard a lot of presentations on that. I warn you, when we met down in Washington, they said the $2,000 and $3,000 wasn't enough this past February, and those numbers were changed. Nobody's coming public and talking about, you're still hearing people talk about $2,000 and $3,000. I warn you that those numbers will change. They have to make up that money in order to sustain this law long term. So if they gave up $18 billion, my guess would be you're looking at a probably $4,000 to $6,000 penalty versus the $2,000 or $3,000. Variable employees. You guys have heard this time and time again, but the details just keep coming out. Basically, they've now told us 30 hours per week is full-time benefit eligible. This gives a huge challenge to you as a district. A lot of your union contracts may be negotiated for 40 hours. I don't know the wording of your contracts. And what's full-time benefit eligible, but full-time benefit eligible now is 30 hours. So that means when you start negotiating again, you're going to have to look at those. I worked with some unions, and they actually have union members, but they're underneath the 40. So they don't get the benefits of the union. They're in the bargaining unit. But now they're going to get the benefits. And so you have to be able to budget for that. For employers who are seasonal or whose hours may fluctuate, you take your current employees and your new employees, and I would recommend that you look at, as you hire a new employee, use common practice. Use reasonably expected to work. If they're reasonably expected to work less than 30 hours, they're variable employees. Or you could fix them and be part-time. You've heard an awful lot in the news of employers who basically, a lot of them in the service industry, where they're fixing the hours of their part-time employees, their wait staff, to not get over 30 hours. Nursing, hospitals are being challenged with this greatly as well, where they'll hire an employee, a part-time nurse at 20 hours a week. They're expecting them to work 20 hours a week. They work, they're mandated to stay because the person that's coming in to relieve them calls in sick. So they work that double shift. They're going to be looking at those organizations, restaurants, hospitals, to make sure that they're complying and giving people the benefits when they earn them. So they're going to have to count those hours. Initial measurement period of 3 to 12 months. From your perspective in your industry, I would use a 9-month waiting period to coincide with your, or measurement period to coincide with your school year. One of the questions that we got earlier submitted, it was, if the district is planning on offering insurance to all employees, is it still necessary to perform the calculations using the standard measurement period, administrative period, and stability period? As a district, if I'm going to offer, it's a good question, but it gives, to me, a lot of different thoughts. You absolutely do not have to do the measurement period if you're going to offer benefits to everybody. The challenge comes in is, are you going to offer benefits to everybody that works 1 day a week for you? And then what is the impact in your budget to the school district and to your taxpayer if you offer to everybody? The better way to do this, I believe, is to class them. And this is in the law, and you're able to do this. An employer may use different measurement approaches for different classes, provided the approach is consistent for all participants in the applicable class. Some of the classes that could include collectively bargained versus non-union, collectively bargained covered by separate CBAs, salaried versus hourly. This was recently in the news. You saw, Fox carried the story, and it was a owner of a restaurant. A lot of businesses thought that they could get away with different taxpayer ID numbers, that they were separate entities. Well, they're looking at common ownership. Well, this gentleman he was all upset, and he was thinking that he was under the 50 per storefront, so therefore he was not subject to the healthcare reform law. Well, common ownership. He is subject to, they combined all the entities. He's a large employer. He's now subject to the law. And then employees located in different states, which really doesn't impact from a district perspective. But I would look at, in every consortium, and I've said this in other meetings, just did 2 weeks ago to the New York State BOCES a presentation. And from a consortium perspective, what I think you need to do is put in that minimum value plan as a plan offering. Start classing your employees as variable employees that don't necessarily get to your bargaining unit. And if you want to offer benefits, offer them a minimum value plan, like a high deductible health plan, which caps the district's exposure, but you're complying with the law. Educational institutions. This is probably the single biggest challenge that you're going to have from an IRS regulation perspective. You're basically going to have to, I met with several districts. I had one district that had one employee that was a part-time bus driver, was a part-time security guard, was a part-time coach, coached 2 sports, and then subs when they need them. And I said, are you offering them benefits? And how many hours did he do? And they go, well, I don't know. And each entity is each segment that he had worked in, he wasn't eligible for benefits. This law now says that they're your employee. You've got to track their hours. And if they get over 30, if they average over 30, then you have to offer them benefits. And the minimum value and affordable. This is, from a coaching perspective, I know most of the time you're paying your coaches on a per diem, or excuse me, on a capped benefit, $2,000 for a season. You've got to sit down with your athletic director, and you've got to figure out the hours for this person and accumulate those hours. Number of hours coached, number of hours in the bus, going to and from an entity, or a contest, waiting for the kids to get out of the locker room. All that has to be accounted for because they're actually working for you. Even though that stipend that they collected, they accepted it. Just tie an hour to it for yourself, because that's one of the things that they're going to be looking at. If an employee averages 30 hours a week during the school year and 0 hours during the summer, they will qualify. So that's why I said use that 9-month measurement period, because the summer you can't count against them. So you couldn't use a 12-month measurement period as a school district because they're excluding you from being able to do that. And probably the biggest challenge that you have is you have long-term subs. And that's where I think offering, when you define a class as a long-term sub, having within your consortium plan a minimum value plan, you could offer them that high deductible health plan to comply with the law. And you make it affordable for them. If they opt out, that's not your problem. You've complied with the law. You're offering them minimum value coverage. that it's affordable, and they've opted out. We got to go back. In order to cover yourself going forward, we got to go back to the days of waiver forms. So people have to, if you offer them coverage, they don't take it, have them sign a waiver form. Because we're going to go walk through some examples of how we set up measurement periods. But to close out those measurement periods, you want that waiver form, because that completes the circuit for you. Standard measurement period. Okay, this is, I hire a worker, and that worker is variable. I don't know how many hours they're going to work for me. They were absolutely not going to come in, I thought, at 30 hours when I hired them. So I'm going to measure them for the next 12 months. Or, excuse me, the next 9 months in your industry. And as I'm measuring them, basically, I can do it on a quarterly basis. I do it probably every 3 months to just take a check and see what hours they're working. You don't have to do this on a month-to-month basis. And then you have up to 90 days to get them enrolled in the benefit. I would typically take to cycle into your normal enrollment. If you are enrolling all your employees for a 7-1 or 9-1, or some districts I've worked with have actually a 1-1 open enrollment, I would get to that same window with that employee, meaning that I would measure all my variable employees over the next, well, if I have a 1-1 date, I would use up until 10, till October, to calculate their hours. If I have a 9-1 date, I'd move back 60 days from there. I would calculate from June to June, or 9 months within that time period. So you're actually catching the work of that employee. Then once I find out they're eligible, they're not eligible. If they're eligible, I offer them a plan. This is where in the administrative period, they accept or reject. If they accept, I get them on, and I have to offer them affordable coverage for 9 months. My measurement period and my stability period have to equal. The question that comes up a lot is, okay, that employee who now meets it, gets enrolled, the following year, I'm paying for them, but their hours, they're still a variable employee to me. They haven't moved to that full-time status. It was just last year that they averaged 30 hours. I have to measure them again this next year. They may fall off next year if they're still a variable employee and I haven't moved them to a full permanent job. So these employees really can become cumbersome. There are, at First Niagara, we have tools that we help employers measure this. So there are other consultants that have them as well. I would recommend, if you're going to do this, interview a few. Find somebody that can do this. Take this off the plate for you. And it should help. But the administrative period, I would cycle it. Typically, I use a 60-day window with the groups. I recommend that you get them enrolled on the plan 60 days after you qualify them. Charts are easier. But this basically shows a 12-month. I will, for June, when I come back and do the presentation at your annual event, I will do a 9-month example to show you how to track this so that you'll have it. And if anybody, Matthew has my email address. If anybody wants to see that, please send me him an email. He'll get it to me. I will make sure that you get this prior to then if you want to start working on it now. But it basically says the same thing. Basically, I'm going to measure within that time period Another challenge that I didn't mention is I've got my variable population today. I hire somebody 3 months in. Their measurement period, I'm going to measure them separately for the next 9 months that they get hired. That employee, if they're with me next year, that new employee, if they're with me next year, but they're still variable employee, they can be lumped into my other variable employees. I don't have to track them separately forever, but I do for that first year. That's a big challenge. I've talked with one district that didn't even have a payroll system that tracked hours. You're eligible for benefits or not eligible for benefits, based on job description, based on defined job. They had to buy a system that could track the hours worked. So it's going to be a big challenge. Now the affordability component. Everybody's heard a lot about this on the news. When the law first came out, and this is one thing that we were very successful of because this came out in March, and it was defined as household income in March. And we said, how are you going to find out what household income is? How is my HR person going to find that out? And what was worse was they actually said, well, we got a solution. Their first solution is we were all going to line up at a local social services department, and we'd take our taxes in there, and they would define what our household income was, and we were going to take that back to our HR person. Luckily, they saw the light of it rather quickly and said, yeah, you know what? We can't make employers accountable for understanding what the household income is and hold them accountable. So they came back with 3 safe harbors that they quickly recommended, and this was basically in March of the second year of 2011. And they said, single coverage must not exceed 9.5% of my employees' W-2 Box 1. You as an employer are not being judged on what you charge your employee for their family coverage. You're being judged on what comes out of their paycheck, that it's no more than 9.5% of that single coverage that you're offering. And this is another positive about offering a second minimum value plan. If I offered that second option and I had people buy up to that richer option, I'm only being held accountable for that the lowest minimum value plan. So from a strategy perspective, we have a lot of groups that are actually offering that lower tier, setting their contribution strategy based on that lower tier, having people buy up to that richer benefit. And it caps your liability. What's that for that one? Minimum value. How does an employer determine minimum value and or actual value or affordability? There are calculators posted on Human Health Services and the IRS websites, and I can tell you I've been on them. They're easy. There's about 10-15 fields that you have to fill out, and it's asking you about what's your copay structure, if you're offering copays, what's your deductible, how do you cover inpatient, outpatient. It'll give you a pass-fail. Meets minimum value, doesn't meet minimum value. Again, in New York, I don't see any of our plans really not complying with the minimum value. But that's one of the things they're going to be looking for. And I always think it's great when you're going to get audited by somebody from the IRS or Human Health Services that you use their own tool against them, so that you could just go out there, plug in those, or hire a consultant who can plug that in. You get audited, they're going to walk through the process. Here's my calculator. I ran it through the system, and it's the IRS calculator. Or you can hire an actuary. I would not go to that extreme. Both of these that you're being judged by, Human Health Services and the IRS, those calculators exist. They're on their website. Use them. Or have your TPA or your carrier. If you're fully insured, your carrier is going to tell you whether or not you meet minimum value. They're ultimately held accountable for that as well. This is where I talked about, you guys are not going to be here, ever, from a district perspective. When this law came out, there was an awful lot of discussion that employers were saying, I'm just going to drop my health care. And I'm going to have them all enroll in the exchange. It's going to be $2,000. Look at the money I save. $2,000 is well less than what I'm paying for my single rate and my coverage for my employees. So the reality is we're looking at an open enrollment as we go through the exchange right now. Most employers are keeping their health plan. The only employers that are enrolling the program, and I've got some of those facts when we go through that part of the presentation, are groups under 5 employees are the ones that are enrolling the exchange. Those employers that have over 10 employees, they feel the benefit of offering them the coverage that they're purchasing in the marketplace that brings real value to them, to their employees, and their recruitment on being able to keep those good employees. So you're not going to be here from a district perspective. You're actually not going to be, no full-time employees receives a premium tax credit. The only ones that you could be subject to would be your variable employees. But again, it would only be those variable employees that average over 30 hours a week that you would be penalized for. So that's another important reason for you to track these employees, because if somebody goes out and gets a subsidy on the exchange, you'll get the first 30 free. So calculating how many variable employees do I have, how many are actually potentially going to be exposed to that dollar amount. But I can tell you, understanding that becomes greater and greater. As I mentioned earlier, they gave up $12 billion in these penalties this year. Those numbers, the 2,000 and 3,000, are going to drastically change as we move into the next year. This is healthcare reform. This is kind of a joke. But really what is true is they have hired a lot of IRS agents within healthcare reform. Numbers started out at 16,000. It's somewhere underneath that. Their sole purpose is to go out and penalize employers for not complying with the law. So we've got a free year. Understanding your risk, understanding your exposures, doing your variable calculations on your employees. And I know it sounds complicated. It is when you first start. Once the system is set in place, it won't be hard. It will become normal business for us. But I would start because of the penalties are going to get greater. Groups that were this year, and I know some consortiums that I work with in the Syracuse marketplace, they got hit with a 2.3% insurer's fee. And again, this was another one that we asked our congressmen and women. We said, who's going to pay this? And they go, the insurer. If you had seen your own individual renewals this year, dominant player in my marketplace is Excellus Blue Cross Blue Shield. Excellus Blue Cross Blue Shield on their fully insured renewals actually itemized out the reinsurance fee, the insurer's fee, and the patient-centered outcome fee as part of the reason for and it was about a 4% increase on this year's 1/1/14 renewals. They outlined it specifically because they didn't want to be held accountable in the marketplace for what the law has made them collect on behalf of us as members. So most carriers have done that. I know if you're in a minimum premium plan, those minimum premium plans, we're exposed to this 2.3% increase because by definition in New York State, they are defined as a fully insured plan. We're going to see this number continue to increase. As you see here, they collected $8 billion, and it's going up to $14.3 billion by 2018. Transitional reinsurance, the good and the bad. Remember how I talked about basically, and this does apply to fully insured and self-funded groups. I talked about 1114, there's no pre-existing conditions. Well, somehow we got a fund for those no pre-existing conditions from across the country. Again, in New York State, we didn't have a lot that fell through the cracks. But $63 per member, and they say it's going to decrease by 2016. But insurance companies, if I'm in a fully insured plan, the insurance companies had to assess and put $5.25 on the renewal to collect, which equates to $63 per member. They did 3 times, so it was a $15 impact, $15.75 impact to a family rate. But that was part of what they're collecting and paying to the federal government on those fully insured plans. If you're self-funded, you should be absolutely looking at, and if you're in a minimum premium or a consortium plan where you're still defined as a self-funded, or a fully insured plan, your TPA, I'm sure, calculated this into your premium equivalent. I'd ask that question if they didn't, these fees, because you have negotiated your contracts with your unions, and you want to make sure that these fixed costs that are now being passed to you funnel back to the federal government, that everybody's paying their share. This should not just be a fixed cost to the district, that they are incorporated in your premium credit. And, let me go through some other questions that I've got here. Question that I had that came in was, can we offer different insurance packages to different members of the same bargaining unit? Question to that would be, yes, if I offered, like I had said before, if I offered a minimum value plan, that's a lower plan, and then I had that richer plan design that they had bargained for. I could offer that minimum value plan, have people enroll in that plan, choose it as an option. But can I segment that group that, and I'm trying to think of a specific example, maybe it's because of the same bargaining unit. The example could be if they're 20 hours, but they still comply with that bargaining unit, and I want to offer them benefits. I'm underneath the minimum of 30 hours a week to be eligible for benefits, but they're still in that bargaining unit. They might not have the benefits of health insurance, but me as an organization, I want to decide to offer them benefits. I could absolutely offer them benefits, and I would recommend, because they don't comply, you're doing better than the law, they don't average 30 hours, I could offer them that high deductible health plan within that bargaining unit because they don't meet the 30 that you're going to have to move to. That would be my only recommendation. You can't discriminate, and this question as posed, one of the things that they're going to be looking at, and it's going to challenge some business, not so much in the school world, school district world, but they're going to have discrimination testing. The law has not been defined yet on how they're going to test for this, but it's going to be very similar to 401k discrimination testing, meaning that the wealthy owners can't get better health coverage, or they can't overfund into their 401k plans more than the common worker. So they would be testing if I tried to pick and choose certain employees to offer this plan or that, if it wasn't clearly defined by a separate wall or a distinction of a class of people, and I'm offering that same benefit to everybody in that class, I could be subject to discrimination. That answers that question. And then I wanted to bring out an article, because before we get into the exchange, I'm a little early here, but the Cadillac tax piece is going to take some time. Are we getting questions? Nothing yet? We're asking, please, to send in questions so we can make it interactive and answer what you guys are looking for. Sticker shock. This was an article written December 15th in the Wall Street Journal. And basically, the couple captions that I thought were interesting is people, as they get enrolled in the ACA compliant exchange plans, which kind of leads into this, is they're seeing a 30% higher rate on average across the country. Again, luckily in New York, we're only seeing about a 6%. We're seeing deductibles changing dramatically in the small group marketplace, but cost for insurance hasn't drastically increased. A lot of what you've seen, and I said this before, a lot of what you've seen is the cost of care, or the reason why plans have been canceled is compliance with the law. This article states that. But then I can keep my doctor, or I can't keep my doctor. Our president, unfortunately, he's recanted it now, but he made that statement: you can keep your health plan, you can keep your doctor. The reality is there's a challenge, and I'm going to talk about that as we go a little bit further into the presentation too. But hospitals are opting out. When you look at how people are enrolling in the exchange, and numbers are all over the board. Kathleen Sebelius' original estimate was they wanted 7 million new Obamacare customers in the first year. December 11th, Huffington Post, Obamacare enrollment surpasses 1 million. December 11th, Fox News reports Obamacare signups rise by $800,000 short of goal. There's a lot of misinformation that goes out there that Huffington Post reported, and basically we had 1.2 million applications of people enrolling. There's filling out an application to enroll in the exchange, but we only have 243,000 across the country that have actually enrolled. So they've gone on, they tested the website, they filled out part of the application. One report saying they're counting just filling out the application. The other one's actually saying you actually enrolled. So we've only gotten, as of December 11th, 243,000 across the country. New York State, we've got about almost half of that population. Our website's working pretty well. However, to get back to this point about the doc, can I keep my doctor? What's happening is nationally across, we're getting 50% of the enrollment in Medicaid that are enrolling in the exchange, which puts a big stressor on our network. It's the single lowest reimbursement to our hospitals and providers. So why I can't keep my doc? My docs are seeing who's enrolling, and my docs are saying, I got to get out. The other thing that happened in the marketplace is the carriers were actually trying to keep a price point to get business. So they dropped some of their high-cost physicians and specialty groups out of it to try and keep their price and get some membership. So there's a lot of games that are going on as far as being able to try to capture membership that are absolutely hurting what the president said, is that you can keep your doctor. Well, you can't keep your doctor because your doctors want to get out of the program because they're getting lower reimbursement patients to come into their facility. So they're opting out of the program. And then the carriers are doing the exact same. They're saying, well, I want to be affordable in the exchange and get membership, so I'm dropping some of my high-cost specialty providers and just offering some of the, so we're losing some of the doctors. So he can't win that discussion because there's competing forces out there. And bottom line is, this article also said that the next shock will come when scores of millions of outside and individual market people who are covered by employers in union plans or on Medicare and Medicaid experience the downsides of Obamacare. There'll be longer waits for hospital visits, doctor's appointments, specialist treatment, as people crowd fewer providers. Again, a restriction of the network means that we're all going to have to wait a little bit longer. And this article also did mention that the Cadillac tax on health plans to help pay for Obamacare starts 4 years from this January. It'll fall heavily on the unions whose plans are expensive due to generous health benefits. The one exemption of the Cadillac tax is the federal health plan. And you're going to start hearing as we move forward, and this gets back to Matthew's point of what happens. Before I get into this, I'm just trying to tell you what's on the news, what's factual, what's not. You've heard an awful lot of discussion from the right side talk about offering a low-cost catastrophic plan, which our President Bush a long time ago, it's almost 5 years ago, tried to reinstitute the high-deductible health plans and the HSAs. That was his push on affordable health care. And then you've also heard McCain talk about purchase across state lines. That's been a theme from the Republican Party. The challenge I've got from that when I've met with our congressmen and women about purchase across state lines, providers give discounts to insurance carriers who have membership. And if I'm sitting in Pennsylvania, and that's where the majority of my membership is, but now I want to write some business in New York, but I don't get a good discount. You may get some short pricing, meaning that the carrier may try to tickle a price in that marketplace to get some membership and hope that that membership will be enough to sustain long-term viability in that marketplace, but it's not going to do it. I think that can actually hurt the consumer, and I've said that to our congressmen and women. Crossing state lines doesn't mean anything. You've got to have the discount. That's the way our financing system works. You've got to work within the means of our financing. Okay. No questions yet, Matt? Okay, we'll start a little bit on the exchange. The marketplace is a new way to find health insurance, and they've called it now the marketplace. They've changed it from the exchange. And we're not going to spend a ton of time on this, but I think it's important to know. And I also think as an employer, if I'm hiring a lot of part-timers, I think using the system that exists can make you, the more you know about this, the better you can be on recruiting. You can keep that 20-hour employee. Yes. Perfect. Yep. Yep, I'll go back to that. And then I'll try and restate that question for you. Okay, question from Laura Hart was, and she's picking right on this point, she has less than 30 variable employees. So she knows I get the first 30 free. Do I have to do the tracking? I guess if you can keep that number at that specific number for the rest of the time, you'd be okay. I would still track that one. I know the tracking seems hard, But tracking 30 employees, I guess I would rather do that and get that person eligible for coverage. But I see your question. That's really your philosophical decision. I can tell you though that question that number is going to go up next year. Great question. You're hitting right on the bubble of whether I do it or not do it. Yep, great. February to June. No. Again, the past practice, basically you've got this first free. So now you've got to set up your policy. Past practice is one thing, but now going forward to comply with the law, you would set up your policy on how you're going to judge your long-term subs. And that would mean, and I know by definition here, I can set up a class. That is a class for me. Long-term subs are a class of employee. So therefore, I could define and set up my own measurement period for that employee. Okay, or that class of employees. And I would use a 9-month judgment period, or measurement period. And that would allow me through that school year, because you're talking about, your question was, if they were hired in February to June, well, they're not working my full 9 months. So I want to minimize my exposure, but I'm being fair to everybody in that class. So I would definitely set up a separate class and set up a separate measurement for that individual. And then again, what I would look to be doing long-term for long-term subs, you're gonna always have them. From a consortium perspective or your district's perspective, I would look at putting a minimum value plan in for that employee that allows you to comply with the law but doesn't expose you to the full expense of your full-time employees. That to me is the solution that will work. Great. Sure. What is the best way to determine affordability for a variable employee? Well, basically first year I'm going to do my measurement. Okay, so I'm going to set up that standard measurement period. I don't have to offer to them this first year. So I'm going to measure them and see where they fit. And again, I could pick for a separate class one of these 3 safe harbors for each class. So, if I wanted single coverage must not exceed 9.5% of employees W-2 box 1, I could pick that. If I wanted to use employees' rate of pay, and that probably is where you're going to be looking with your variable subs, is because working sometimes long. My recommendation would probably be here. Bear in mind that if they're a family, though, that 9.5% is only comparable to the single rate of the plan that you're using. So even if they purchase the family coverage, you're not being held accountable for that family coverage. Hope that answered the question. Anything else? Sure. This makes it easy. It's more engaging than me just preaching to you. Lorraine asked the question, who would pay the Cadillac tax? And we'll get into detail on that going forward. But the question would be answered like this. Ultimately, it is, if I'm in a fully insured plan, the carrier is going to build that into my premium rates, bill me for it. okay, as an employer. Then it's down to my contract negotiations. So if I've got the district's paying 90%, the contract says they're only paying 10% of the rate. They're picking up 10%, my employee, I'm picking up 90% as a district. So it comes down to both that's going to pay the Cadillac tax. Ultimately, it falls to the employer's responsibility. One of the things I've said to get the unions to spark a good conversation with them and start talking about this is to say, going forward, as you're sitting down for your next contract negotiations, if 2018 comes and we don't have a different plan design to stay underneath that threshold, you're going to pay 100% of the Cadillac. Well, that conversation will go well, but the reality is that starts them thinking about that, because now you as a district are trying to transfer 100% of that Cadillac tax to them. Hopefully that gets you to a different starting point in negotiations to pick a plan design that's going to work better for everybody and keep you underneath that threshold. So that's the first blush pushback that you'd have to give from a negotiation perspective. Another question? A subcontractor 1099 employee has own equipment. Basically, they've provided you liability or workers' comp liability, their own auto, they slip and fall on your premises. They've already given you that rider. It'd be very similar to me on what I do for school districts. I come in and I work for a fee for service. I am a subcontractor. I get the same pay. So bottom line is, I would not be subject to earning employee benefits at your district. Okay? Jane asked, do we have to offer family coverage to variable employees? Well, as we go further down, in 2015, you have to offer dependent coverage to your variable employees. You do not have to offer spousal coverage. And taking away my joke without the slide up there, but I'll say it anyways. I think the congressman or woman that wrote that piece, I think was in the middle of a divorce, so they didn't want spouse to be covered. But the reality is, you are only being judged from an employer perspective to make it affordable for your employee. You don't have to make it affordable for the dependents or their spouse. So I would offer it, but you don't have to make it affordable. So that does change some of your contribution strategy that you've negotiated in the past. And that's a good point as I'm talking here is the other thing that I've said when the district has brought me into the unions was, look, common practice has always been to make it affordable for you, the employee, and the dependents. That's been common practice. The law now, with the stresses of the law and our compliance of the law, also has made it in such a way that you need to know we don't have to make it. The law says we don't have to make it affordable for your dependents. I only have to make it affordable for you, my employee. And so, therefore, we ought to be able to sit around the table and talk about how can we accomplish everything that we've done in the past, but yet get to avoiding that Cadillac tax going forward. So those are things that you bring up in negotiations that I think enlightens them. They don't really think that the law allows you as an employer not to cover their dependents. UPS, this happened probably about 60 days ago now. UPS launched, and depending on what network you watched, you got a different spin. Fox News, and this was UPS, basically their headline, Fox News said, this is a consequence of healthcare reform. A major employer like UPS is dropping all spouses off their medical plan. That wasn't the case. spousal language has existed across the country forever. It hasn't necessarily increased or existed in New York as much as the rest of the Midwest. But really all that was employers saying, UPS said, I have to make it affordable for all my employees. And if I make it affordable for everybody, their whole family, then where's that other employer feeling the pain that I'm feeling? So UPS said, bottom line, if my spouse has available coverage at their employer, they have to get it there. And let that other employer feel the accountability of making it affordable for them. That's really the truth of what took place there. My own employer, First Niagara Bank, they implemented that this year as well. That you get your coverage through your spouse. Or that if my spouse has coverage, she has to get it through her employer, I have to get it through mine. So that will be a change in the marketplace, more so on the East Coast. Any other questions? Okay. Get back. Thank you for those questions. Into the marketplace a little bit. This, you've heard an awful lot on the news. And this again, I just want to give you a highlight. Don't want to talk much about this. But the red states are all states that basically form their own exchange. New York's is operating pretty well. The dark states, the darker gray states, defaulted to the federal exchange. And basically, if you're not following much on the exchange, there are two things that took place. One was there's an individual exchange where I can purchase if I don't have health coverage. Then there's a small business exchange, 2 to 50 as defined by the federal government, that I can purchase through this community rated environment. You've heard on the news another thing that our president basically delayed was the shop exchange, the small business exchange in all these dark gray states that had deferred to the federal government and said, I want my small group exchange to be run by you. So that was delayed until 2015. The federal government couldn't get that operational. They were having enough problem getting those 26 states operational for the individual mandate. The delay has also taken place on the individual mandate that our president said basically he gave a blanket statement for the whole country that there is no individual mandate penalty until after March 31st. He gave a 90-day delay on the individual mandate as well because the federal exchange website couldn't get up and running. One application can qualify you for Medicaid, Child Health Plus, tax credits. The websites are up and running. I think the challenge comes here is that you earn as much as $92,000 a year and you can qualify for a subsidy. That's the challenge, is how do we, that just pulls in a lot more people that's getting subsidized by us from a federal government perspective, as a taxpayer perspective, that we're reducing their health care and they're making $92,000 a year. Won't belabor this, but the system is supposed to be really easy to obtain. I'm glad to report that I read a news article. They actually just pulled in a Microsoft exec to help get the federal exchange up and operational. So he's an ex-Microsoft employee, but they pulled him in to hopefully try and get the system up and running better. So they should have probably done that in the beginning. This is our website. It's up and running, and it looks it's working pretty easy. I was on it here about 15 days ago, and in about a 45-minute period, I only got kicked off once. So that's good. That can just be the internet. That doesn't have to be the server. So, there's a good pricing component. I think what's neat, if you go out there and you look at the website, I did slide in here, and we'll get into that after our break, but I did slide in there some of the plan designs that exist in the small group exchange as well as in the individual exchange. And the plans are not comparable to what we have today in this marketplace. It is a drastic change. And what we do when we're working with employer groups is we'll go out and we'll say that. Because you're going to hear talk. Everybody thought that these plans were going to be so much better in the marketplace. The reality is, when you look at the plan designs, they're saying, holy cow, my plan is so much better than what exists in the marketplace. For those that didn't have insurance, it's great. I mean, they're getting covered. But for those of us that had to change, it isn't what we thought it was going to be in concept. Here's the individual exchange. The Platinum plan, which is supposed to be the best plan out there, has a $3,000 out-of-pocket. If I go into an inpatient, it's a $750 copay. Now that's the premier Platinum plan. It's got a $200 outpatient copay for outpatient facility, $200 copay for ER. Now, if I'm a person that doesn't have insurance, yeah, this makes sense. It's more affordable than what I was able to purchase. The drug copays are $10, $30, and $50. In the middle, you see the silver CSR versions. Those are on the silver versions if I am to get a subsidy. If I sit between 200 and 250% of the federal poverty level, I will have a $1,500 deductible that has to be met before any of the other benefits below get paid. And I have a worst case scenario of $4,000 out of pocket. Again, my inpatient facility copay, $1,500. That's a silver plan. So, but the lower I go, this is a good thing. I do like this. The lower I go from an income perspective, my benefits get enhanced. So it takes that same plan design. If I'm now sitting at 100 to 150% of poverty, I don't have a deductible that I have to meet up front, but I do have a $200 inpatient copay. I do have a $50 copay for outpatient facilities. I do have a $50 copay, or 50%. It's 50%, yeah. No, excuse me. 50, 75, 75. Can't read it off the computer screen. I'm 48, and I guess I'm going to get glasses. Physician office visits, $10 copay. So from how they constructed this, I do see value from how they have enhanced the benefits for those that make less. But it's a far cry from what we've seen in the benefit world that existed in this state prior to it. Participating carriers in the exchange, pretty much everybody participated. Health Republic is a TPA that actually put together a fully insured plan. They rented a network. They got a grant from the federal government, and this was really a challenge to see, can they bring something different to the marketplace? The challenge with this is they basically rented a network. They didn't create their network, so there's really virtually no discounts there. They are substantially the lowest priced provider or carrier in the marketplace, which means they're going to get quite a bit of membership this year. But the price, the challenge is going to be the sustainability of the pricing next year for that. And I think, and hopefully the federal government at that point looks at it and said, well, maybe you need membership in order to get discounts, like the carriers have brought to the table, because it's just going to be trading money. And I just wanted to show you, this is a change that in a small group marketplace that I did with a current employer. Unconsequented or unintended changes or unintended consequences of the law. This is a small municipality that bought a high deductible health plan. They had 2-tier rates, because that's where the majority of their membership was. This plan is no longer available. It was a $2,600 deductible, $5,200 for a family. They funded 100% of the deductible. The municipality did. So it was first hour coverage for their employees. The law came in order to be compliant with the law, and Excellus basically threw this plan away. The plan no longer exists. The closest thing that they could get was this $2,200, $4,400 deductible plan with 4-tier rates. Cost them 16.5% or 16.15% more in their fixed insurance cost. Just again, unintended consequences of the law. The plan that they had, this is a prime example of, you want your plan, you can keep it. Oh, this plan's gone. Carrier discontinued it. These are sample small business plans. And I think it's appropriate. I've asked the question, and I know somebody on the phone is going to, or somebody on web is going to ask me the same question, and I think I got the answer. These exchange plans, are they going to be subject to the Cadillac tax? I asked this question when I got out of Washington. And I guarantee you the answer that they're going to tell me when they actually put it out in print is no, because they're the exchange. They're an exempt federal plan that we've set up. Or an exchange that we've set up, so they'll be exempt. But these rates, look at this. A $1,500 family of 4. So they're going to be a Cadillac tax rate come 2018. Out of pocket $6,350, $12,700. This is the richest plan that exists in the exchange. $529 for a single. The next plan is, they call it the gold plan. Again, I don't know that I'd call it gold. It's a $600 deductible, $1,200 per family, $4,000 out of pocket, $2,540 copay, $1,000 inpatient copay after the deductible. That's a gold plan. And it still carries a $1,300 family rate. $2,000, $4,000 silver plan, you're back to $1,100, and that's really a qualified high deductible health plan. Well, excuse me, no it is not. This is a qualified high deductible health plan, HSA qualified. But that has a $4,500 deductible, $9,000 for a family. My out-of-pocket is a $6,350. Everything in that last plan is subject to deductible. This plan, I have to meet my deductible. Then I have a $30 office visit or $50 for specialist. I go to an inpatient, I get a $1,500 inpatient copay. We like to share these in meetings with groups to show, hey, this is what the marketplace is. Just so that the employees understand that here's a platinum, gold, silver, bronze. Not making them up. Here's they are. You can go out on the website. You can look at them. These are the plan designs. Now compare it to what you have. It just takes a lot of noise out of your organization about what exists in the marketplace. And I think we'll stop here and send in more questions. Take our 15-minute break, and then we'll finish up. And more questions. It helps. Doesn't make it as dry. Okay. We should be good. Okay. Welcome back. We have some more questions. There was a question posed, and basically it was on tracking employees and basically capping hours is how it was posed, meaning that I keep them underneath that 30 threshold. Locally in Syracuse, we had a couple of restaurants, Applebee's being one of them, owned by a chain. He owned 6 or 7. He basically came right out and said he was going to cap everybody at 25 hours and hire more employees. Basically, changing your business practice is exactly what the federal government is looking for. Altering the way you did business yesterday to avoid the law today. You can do it over time with a business reason. And that's why tracking the variable employees, I would recommend that you track them. I would also recommend that as you go through, as you're going through this process, you're going to see those people that potentially could be eligible. That may cause you to hire a couple more long-term subs or part-time employees to adjust for those hours. That can be a business practice. But if you blatantly come public like the Applebee's owner did, he said, I'm just doing it, and they can't tell me how to run my business. Well, they'll see him in an audit, and he'll be paying his penalties. You can absolutely do that. So that was the core of that question. I would look to keep them. I wouldn't keep them if you're going to do that as a business practice. I wouldn't just try to hold them at 29 hours. That's too flagrant. I'd keep them at 25. Something and monitor that and make sure that you comply with that. 29 to me means why not 30? I mean, that's pretty bold to just go 1 hour less. Okay, next question is long-term sub-teacher from February to June, okay, working full-time. Our measurement period is 9 months. Does the sub qualify for benefits next year? Well, if in that 9 months they qualify for benefits next year. That is absolutely correct. You're judging them this year for eligibility for benefits next year. And then what you're going to have to judge them again next year because that same long-term sub may not qualify for benefits for the following year, and then you're going to have to disenroll them. So it is more of a monitoring process, and it's going to become a challenge. There are tools out there. There are don't reinvent the wheel. There are a lot of consultants that have tools that are available that you can just pay a small fee to get access to that tool and do the accounting yourself. The next question is regarding full-time employee determination after in the initial measurement period and the administrative period, the employer offers coverage to the employee at the beginning of the stability period. What if the employee is no longer working for the district as the start of the stability period? In other words, we are required to cover a long-term sub teacher for part-time period of July 1, 15 through June 30th, 2016. Your sole responsibility, chances are if that employee meets their eligibility component, that's what the question was asking, and then you go to offer, you've already made the offer, and yet when it comes time, they're not your employee anymore. It becomes a COBRA situation. But again, you as an employer, if they're not working, chances are they can't pay the premium. The minute that they don't pay the premium, they're like every other employee. You can terminate them, disenroll them. The challenge is going to become, I think, more of that employee who's variable that meets eligibility this year by the hours worked. Next year, their hours get cut in half. and you offer them based on last year's performance, again, you as an employer, all you're going to have to do, okay, you're eligible based on last year's performance. I'm giving you the benefits. I'm making it affordable for you. If you don't buy it, sign that waiver form. Your responsibility ends there as an employer perspective. You offered it. You measured them. They're eligible now for this time period. They opt out. Sign the waiver. They're held accountable for the individual mandate. 2015. Oh, okay. Thank you. Yes, you did. Okay, perfect. Long-term question is, long-term sub works 37 hours per week for 8 weeks. Is the formula the following? 37 times 39 weeks of school. Okay, the question was 37 times 39 weeks of school, or 296 total hours. So she worked 37 hours per week for 8 weeks. Basically, yeah, I mean, you would multiply 30 hours times your measurement period. You're going to track their own individual hours work. She came up with a 20 and a half hour per average week. You are really looking at monitoring this person for the 9 months, looking at the hours that they actually work, not penalizing them for all the holidays that you get. That gets actually credited in their favor as hours worked if they're employed. Snow days, they get them. So whether they're on the clock or not. But if they're a long-term sub, chances are they were scheduled to work the day this got canceled. And I think hopefully this gets year 2 of this. When we actually start implementing this, I think you're going to see more and more edits to this component because it's going to become a huge obstacle for you. The goal is you as an employer are going to actually make these people eligible the following year. They don't work the hours that they worked the year before. When you determine their eligibility, you're doing all this tracking. They're not buying. What's it all for? You know? So again, I'm telling you the way the law is written today, we got to track them. And we got to offer if they meet that eligibility. If they buy, it's no skin off your nose. If they buy or not buy, your job ends at qualifying them, offering them the coverage if they meet the eligibility, minimum and affordable coverage, only on the single, as it relates to the single rate. They can buy for family. As you can see right here, 2015, employers with 50 or more full-time employees must offer health insurance to employees and dependents, but they exclude spouse. Again, I'd use that in negotiations, start talking about that now. That clearly states that I have to offer dependents, I don't have to make it affordable. I only have to make it affordable for my employees. I don't have to offer to your spouse. I use the example when I'm talking to your unions, when I'm in front of them on your behalf and say, you knew UPS did this is what UPS did. They excluded spouses who have coverage affordable elsewhere. This IRS reporting has been released, and you'll be getting details of that. In 2015, you as a large group employer are going to have to report to Human Health Services. Initially, it came out and said that you had to report on a monthly basis to Human Health Services. We said, Human Health Services is going to actually look at this on a monthly basis. You have to report on an annual basis to Human Health Services. They've redefined it. But you still have to monthly account for every employee enrolled or disenrolled on your plan. So you're going to have Johnny Jones enrolled from point A to point B with you. How much are you charging them? How are they enrolled? If they opted out, you're going to have to record that. And I'll be able to give you a template of all the categories that you're actually going to have to comply with and email that to Human Health Services. But that's not till 2015. So that got put off. It was supposed to start this January. Now the goal behind that, and again, I can't argue with this, is as we're looking at the subsidies and people qualifying and saying they could go to a Human Health Services without accounting and say, my employer doesn't offer me affordable coverage. And you do. And you could get penalized, depending on how many actually did it, unless there was this tracking mechanism. This tracking mechanism, basically, this is going to sit at Human Health Services now. So one of your employees goes to the New York State Exchange, they try to get a subsidy. They try to qualify. They say, my employer doesn't offer minimum value affordable coverage. The state is going to contact Human Health Services. Human Health Services is going to say, nope, employers, Johnny Jones, boom, boom, boom. They were offered coverage. It was affordable. They offer this minimum value plan. It meets all compliance. It stops the voucher right there. It stops that employee being able to get a subsidy. How they were trying to make this work for 2014 is if your employee did that, the exchange was going to call you up and said, hey, we got an application from Johnny. Johnny says it's not affordable and meet minimum value. You would have had basically 30 days to send back notice. Nope, it's not true, and prove it. So once this is up in place, again, it's accounting, Excel file. You should be able to pull it based on contribution strategy from your payroll department. It should be pretty easy to pull. But that is going to be required. 2016, 51 to 100 employee groups are going to be eligible for the exchange or the marketplace. And then in 2017, states can open the exchange to any size group. But in 2017, there's no more federal funding as it was originally written. Those $2,000 penalties that you as an employer were going to be subject to pay, or $3,000, was going to subsidize the building of the exchange and the financing of the exchange. Those numbers are going to go up for 2015. So my guess is this will be pushed off because after 2016, exchanges were supposed to be self-sustainable and not get any federal funding. And actually, it really wasn't federal funding, it was employer funding through the penalties. But my guess is this will pop down a year. There'll be 2 years of penalties, employer penalties, and then in 2018, they'll go to large group. So the exchanges will get an extra. Getting into the Cadillac tax piece, there seems to be, I guess I'll close with those, but there seems to be a lot of confusion. The only group, federal government is the only plan that is exempt from the Cadillac tax. And the confusion lies is that most government entities don't have to pay excise tax. So that's where the first thought process was that school districts, municipalities would not have to be subject to this tax. They came out with guidance and clearly stated that nope, every local municipality and school districts, as well as every other business, are subject to this 40% excise tax. So it's for every dollar, and this is going to affect for all group plans, fully insured, including self-funded plans. Self-funded plans, if you're calculating your premium equivalents become your fully insured rate. So that will be what is used to calculate. And again, if you're self-funded and you have over 250 employees, you're already reporting on your W-2 how much you pay as an employer and how much your employees pay. But it's for every dollar over and above the $10,200 for individuals or $27,500 for families. Carries a 40% excise tax. What is excluded from a Cadillac tax? If you have an accident-only plan or disability income, supplemental liability or auto liability, workers' comp, separate dental and vision plans. Some plans, some self-funded plans that I had actually had an embedded dental and vision plan built into one rate. It forced those to be broken out. I had one group that just gave a HRA, health reimbursement account, to their union membership, $700 for their dental and vision coverage. Well, that HRA, as we'll see as we go further, is defined as an insurance premium. It was an allocation in their name, even though they didn't spend it. It got added to the Cadillac tax. So what we've done with that entity is we've taken that pot of money that they used to do. They bought them separate dental and vision. We just took that same premium bucket of money that they were spending and allocating, and we saved over $40,000 in a potential Cadillac tax. Just by figuring out how to work the law to not expose the group and the union membership to that. Benefits for which medical care is secondary. Employee includes, this is a big one. And I know a lot of districts have, and governments have surviving spouse. Employee includes any former employee or surviving spouse is subject to that Cadillac. So, ultimately, and this is where you're going to get more and more guidance coming out, but ultimately it is the employer's responsibility to report to the IRS and coverage providers. Now, where you're going to be reporting on that is, remember that 2015, you're going to have to put how much you pay, how much your employer pays. That's already going to go to Human Health Services. So while this bullet may seem scary, it's already there. You're already reporting on it in your new report that you have to do on 2015. Multiple employer plans, plan sponsor will calculate and report. So your consortium plans, basically your TPA, or your carrier that's involved will be reporting. Coverage provider is responsible for paying the tax. Again, this is what we said. Okay. They're responsible for paying. So Blue Cross Blue Shield is going to do a flow-through system. They're going to pass it down to you. That for any dollar amount over and above it, they're going to calculate. And this becomes concerning, and I talk about this with unions, because you may have a plan that the single rate hits Cadillac tax threshold, but the family rate doesn't get there, depending on your claims and your single to family mix. So now you have some union membership incurring a Cadillac tax, while the other union membership doesn't get hit at all. And they'll be saying, why is it that they have to pay it, and I have to pay it, and they don't have to? So it's going to create some interesting dynamics as this unfolds, because not everybody is going to get it. The carrier is going to bill for it. They're going to submit and pay on your behalf. So it's not their bill. It's your bill as an employer. They're responsible to submit it to the federal government. Cost of coverage is determined by applicable COBRA premiums, and that's for self-funded plans. FSA coverage includes both employee and employer contributions. HSA contributions count. So all my pre-tax, in essence, the way I read this, if I have a flexible spending account and I had 3 kids that went through braces, best thing in the world is having a flexible spending account, because I paid pre-tax dollar for that monthly payment that I got for 2 years on each kid. But I paid for it with a pre-tax dollar. Have your kids go now, even if it's premature. Because come 2018, whatever dollar amount you put into a flexible spending account, and this gets even more confusing as an employer, you're going to have to, and that's where it says that the employer is responsible to report the Cadillac tax because you have multiple vendors in there. If you offer a flexible spending account, your TPA may or may not be the provider of that, your third-party administrator. So you're going to have that bucket that you're going to have to keep track of. You're going to have your COBRA premium rates. And then if you had any HSA contributions, you're going to have to tally that. Only about 20% of your population, probably, or 30%, actually take advantage of a flexible spending account. So 20 to 30% of your population is going to be paying more in a Cadillac tax. In essence, I think from a streamlined perspective as an employer, come 2018, unless they change this part of the law, there is no more flex. I mean, you as an employer, the cap is already at $2,500. They took it from $5,000 down to $2,500. So I think most employers are going to eliminate that, which is exactly pretty much I think what the federal government wanted was because now guess what? I'm paying with after-tax dollars for medical benefits. So they get their 30% of me. And I don't get that. It's really kind of forcing us to move away from that benefit. Now, there's a lot of employers that, not so much in the school district world, but in the municipal world, in the small municipalities, they have moved to a high deductible health plan and they're funding the deductible contribution into their employees. As well, the employee's contribution and the employer's contribution, plus the premium that's paid, gets added together. So even a lot of small municipalities cite that example that I did before. They were putting $5,200 in a family's bank account to cover their deductible. On top of the premium. That plan, by 2018, would be taxed, or would become a Cadillac tax. If your monthly premium, and they set this rate as is today, they're gonna index it by CPI. So you might look at a 1 or 2% increase after 2018. But if your monthly premium is $850, over $850 or more now, you're subject to it. And bear in mind that if you're offering a flex, you might already have people that are already there. And one of the things that you should be looking at, and I look at with, I do a Cadillac tax estimator with groups. And basically that is to take a 5% trend, 6%, whatever you feel is the number. Do that calculator between now and 2018. Look at the flex people that you have maybe and see what your exposure is. There was a small municipality, 300 employees that I dealt with, did this calculator for them. They were actually at $345,000 and they're enrolled in the NISHIP plan. And they're getting a 7% increase on an annual basis. And I just took that out to 2018. And I presented it back and I said, here's what you should start talking to your unions about. Look, without changing a plan design, this has been normal trend increase. This is what we're going to be subject to. Help me. And the administrator basically came back to me and said, well, Mike, he goes, bottom line, here's what I think I'm going to do. I'm not going to be picking up trash anymore. So basically, the owner of a city, he was saying he was going to eliminate a whole department, subcontract it out, save money, if he couldn't get to terms with his union. So having these upfront discussions with your bargaining units now, it's not going to be a fun conversation, but you need to have it. They need to understand this is going to impact them, impact the district, impact the taxpayer in your district. It's a big challenge. Do we have any questions that came in on that? Okay. Coverage, cost of coverage, we did that. Individual mandate. This also has, our president has delayed that until March 31st of 2014. And this was a function of the insurance exchanges not getting up and running. At the end of the day, the penalty isn't great enough. It's only 1% of my family income for me to get in there. And the individual exchange, or excuse me, the whole way we can make this affordable is getting our youth enrolled. Those that aren't offered employer-sponsored plans, they have to. The challenge is we're only enrolling those people that are over 26 to, say, 30 is what we're looking to get enrolled in the exchange, because my daughter's 23. She's going to ride it for another 3 years. We opened it up to 26. So our kids are still on our plans. It's not like they're not insured. It's just they're not going to be insured in the pool, the exchange pool. So that fee is not great enough. I think you're going to see a further ramp up of that, a readjustment, similar to what you're going to see a readjustment because of this delay. I mean, depending on what you heard on the news, but the Republicans were actually pushing for if we gave a year pass on employers to not have to pay a penalty for being in compliance with the law, the Republicans were pushing for and actually looked at a $36 billion savings to delay this for a year. And the reason why there was going to be that savings was behind the scenes, there's the subsidies that are being paid. So you actually get people enrolled, it costs us money. So if you don't make them be accountable to get enrolled this year, the Republicans said, well, at least if we're not holding the employers accountable for it for a year, then at least we can save $36 billion in this that we're actually going to have to pay out to get people enrolled in the program. That was the counterpoint argument of how they were going back and forth. This, to me, is the biggest concern, and you're hearing doc shock, you're hearing limited access of networks. Bottom line is, across the country, we're seeing 50% of the enrollment going into the exchange is in the Medicaid reimbursement. It is the lowest reimbursement to our providers and hospitals. We got 7,000 people a day qualifying for Medicare. Second lowest reimbursement, and it's just based on age. Yes, ma'am. Yes. Yep. Dan's question is, basically, come 2018, my single premium is $900 a month, and then my flex contribution is $2,000. The employee, if that is all employer money in the flex, that becomes my 40% responsibility as an employee. So once I know that as an enrolled employee, I'm not going to be enrolled in that anymore. I'm losing 40 cents. It's more than what I actually would have to pay tax on if I paid with after-tax dollars. So I'll drop my flex. And I ultimately think that that's what's going to happen come 2018. The way this law is constructed right now is there will be no more flex come 2018. The $50, the rate is $850. You're at $900 come 2018. You pay 50% or 40% of that $50 a month. And it's going to be split based on your contracts with your employees. The carrier, if you're fully insured or at a minimum premium plan, the carrier is going to build that into your rate for those that are over and above that dollar amount. They're going to bill you for it. You're going to pay it. You're going to pay it and assess it based on the contracts for your employees. So if there's a 10% contribution structure, they're going to pay 10% of that $20 a month, because 40% of $50 would be $20 that you're exposed to. So 90% of that $20 is going to be the district. 10%, if that's my contribution breakdown with my union, 10% of that, or $2, is going to be the exposure to the employee in their deduction. Employee contribution. Good. So we're getting 7,000 people that are enrolling a day in Medicare, second lowest reimbursement. We're all enrolled here. Doctors are doctors are looking at their patient base right now. As I cited earlier, we've got actually in California, I got a slide here, just locally, New York, Connecticut, but California has been really vocal in this. Memorial Sloan Kettering has dropped out of all the exchanges. And it's because they don't want to be held accountable for who gets enrolled. Connecticut, hospitals not network on the exchange. Norwalk Hospital, St. Francis Hospital, Lawrence Memorial Hospital. 3 key hospitals. Anthem Blue Cross says that there's about 85 to 90% of the network that they have off the exchange is in the exchange. So there's a 10 to 15% network drop for people that are enrolling in the exchange. In California, it's even worse. Their exchange offers only 50% of the doctors and providers in hospitals and excludes top-notch hospitals like UCL and Cedars-Sinai. That Wall Street article that I quoted a little bit earlier, they actually said this is going to potentially create, and I do think this, is going to create potentially a worse have or have not society. If I'm wealthy and I have the ability to pay cash, in Syracuse, New York, we had an internal medicine physician that had practiced, and this is happening all across the country. He'd been practicing for 20 years. He had 2,000 patients. He basically looked at his book of business and said, pay me $1,500. I know you have the ability to pay me. He approached each one of his patients, and you'll get 24/7 concierge care. You still need health care because I'm just not going to participate with anybody anymore. The guy's making $600,000 a year, doesn't have to provide billing staff. He's got it, and he's dropped his malpractice insurance because he went from covering 2,000 families to 500. So he's living life large, and that's the scariest part. Is when you see this is the ones that we're going to have practicing with us going forward is those that have been in the business the longest don't have to play. They can choose whether or not they're going to play the system or not. It's our new graduates who have debt to pay. They're going to play in every level because they have to pay off their debt. So we're going to lose our brain trust. That's the scariest part. And when we go down to Washington, we spend more time talking about this. The law as it's written today has done everything to create access, has done nothing to stabilize costs. And that's really what needs to be addressed. And the next administration or whoever wins the next round of elections, they have to focus on the cost factors of this going forward. Again, we showed this, I think, in the last, but I think this is another thing that's wrong with healthcare. These are Medicare reimbursements. These are actual procedures that were paid by Medicare. Joint replacement in Ada, Oklahoma is $5,300. The same procedure in Monterey Park, California, $223,000. That is what's absolutely wrong with our healthcare system. There is no reason that it should cost that much, except for, guess what? Ability to pay. That is core of what our country, how we got. But healthcare, if you believe that everybody should have health care, and our president does, and his administration does, then this should be the single biggest thing that he's trying to address, is making it affordable from a claim perspective, not just on the ability to pay. And we would drastically save a lot of money. Ada, Oklahoma does use fine cherry wood in their joint replacement. I've been there. It's sad that there's that much disparity. And treatment for heart failure, I mean, you see here, Jackson, Mississippi, ranges from $9,400 to $33,000. There's just a huge discrepancy in reimbursements. And then that $81,000 versus $38,000. I mean, that's a positive of what's charged from a facility perspective and what actually gets reimbursed. Is $3,800. With that said, and actually I got a couple more bullets here I think I want to go over. And then I'll open it up for questions. And then like a school teacher, I could say you're dismissed early. Some of the general notices that I think as an employer, 2014 individuals must have health insurance. We know that there's been a buy. There's just seems to be a lot of confusion of these bullets. But it's now, as of April 1, as an individual, I have to have health coverage. Small employers are not required to offer health coverage. Only large group employers. Actually, large group employers aren't required by law, but you're exposed to a penalty. And large group is defined as over 50 full-time equivalents. So the backs of healthcare reform are off our large employers. I mean, the financing of it. The numbers that we saw as the law was originally written is $2,000 for an individual, $3,000 for a family. Over that. Great, that's that. I would absolutely consult with and stay in regular communication with your insurer, plan administrator, along with your benefits administrator, your attorney, and the person who handles your labor relations. I think from a district perspective, get out in front. Try to get language in. If you have to settle a contract today, get language in your CBA that allows you the flexibility of opening should anything change in healthcare reform, that you have the ability to open that contract up with them. Do not sign anything don't sign anything past 2018. Try and be above that date. Allow yourself the flexibility. I would recommend, if you can get away with it, signing 1-year deals. I know that gets you back into the table every year, but the positive of that is it allows you the flexibility as this law changes and evolves. You're not trying to bargain something that may change. That Cadillac tax, we should be taking steps now for 2018. Otherwise, what's going to happen is you're going to hit 2018 and you're going to have to drastically reduce your benefits, create union strife, probably have people walking out in front of your facility on strike. I don't know. People won't be happy. It's better to make steps towards that today. If it doesn't happen, you're taking small strides as opposed to drastic measures come 2018. And I'll take any more questions if anybody's got them. And that's about what the roadmap looks like as far as healthcare reform. More and more stuff. And Matt, you did for me another one, right? Okay, there was some confusion about the sub who works 4 months. Basically, if your measurement period is 9 months, here's probably the confusion that came. I have a select population of long-term subs that come with me come 9/1 when I open the door. They're already employed. They were employed with me last year. Then come along new employees. So I'm now, and that's the answer to that question that said February. I actually start a new measurement period for that new employee. I have a block of variable employees. So I could measure that person for the next 9 months from the date of hire. And that's what I would recommend you do. And granted, you're there. They started in 4 months. If your measurement period is 9 months, they'd have to not average 130 hours per month or 30 hours per week, right? You do not have to offer. Yeah, the question is they have a separate measurement period. So you wouldn't have to offer them this open enrollment. And I guess there was misunderstanding of how I answered the question the last time. That individual employee gets their own individual measurement period based on them starting in February. Okay?
If I offer insurance to all sons, coaches, etc., and they are not covered in CPI,
if I offer coverage to all coaches, I just want to make sure that I heard the question right. If I offer, they're not in a CBA, I offer them coverage, but what threw me was the last statement, they pay 100%. The problem comes if those employees, there is no problem if all of them average under 30 hours. You don't have to make it affordable. The problem comes is you have to find those employees that average the 30 hours, and then you're held accountable to the affordability. You get, obviously, those first few free, but you have to make it affordable for every employee that meets the criteria. That's it. If anybody, I know Matthew has my email address. I will absolutely, and actually, Matt, I guess the thing I'd like from you is give me email addresses for everybody that's on here. If they want, they can respond to you if they want to opt in for this. But any further questions that you get, I can respond back to everybody with the questions and give them those so that you can develop your question-answer database. Okay? With that, I release you early. Thank you.